Tell me when to start.
You can start now.
Yes. Good evening to everybody and welcome to yet another CLIP session, Clinical Practice Oriented Webinar Series of ISA National. So I welcome the academic facilitators for today's event, Dr. Rashi Sarna, Assistant Professor, Postgraduate Institute of Medical Education and Research, Chandigarh, and Dr. Maya Masan, Senior Consultant and Head of Department of Anesthesia and Critical Care, CHL 114, Indore. I request the academic facilitators, Dr. Rashi and Dr. Mayank, to please take over the proceedings.
Thank you so much, Dr. Madhuri Kurdi, for handing us over. Warm welcome to all the audience as well as to our respected, first of all, the Honorary Secretary ISA National, Dr. Gyan Sagar Bajwa sir, and the Program Head, Dr. Manoj Kumar sir. Sir, can you please, Gyan Sagar Bajwa sir, can you please give the welcome? We request you to deliver a welcome address to our moderators, the panelists, and the respected audience.
Thank you, Mayank. But I don't think so there is any time to welcome everybody. Just simple welcome to everyone. You can start the proceeding. Let's concentrate more on the topic today. So I hand over back to you people. Just start it.
Right, sir. So over to Dr. Rashi Sarna for introducing our moderators as well as the panelists.
Thank you so much, sir. So the moderator for today's session is Dr. Ranju Singh, who's a Director Professor, Lady Hardinge Medical College. Her area for interest are obstetric anesthesia, pediatric anesthesia, and life support. She's been awarded the Honorary Fellowship of Indian College of Anesthesiologists. She's an ISA Delhi President Appreciation Award, an ISA Diligent Award, and a COVID Warrior Award by the Brahm Kumaris. Amongst us, next we have let me share the screen with you.
No issues.
Dr. Nishant, please share the screen. Nishant will share the screen.
Next, amongst the panelists, we have Dr. Datta Prasanna Katikar, who is a consultant neurological and spine surgeon from Balwant Institute of Neurosurgery and Intensive Trauma Care, Solapur. He's a neurosurgeon and a spine surgeon, and he's been he's the president Midwest chapter of Neurological Surgeon. Then amongst us, we have Dr. Sri Vidya, who's a medical director of Apollo Hospital. And her areas of interest is preventive health services and diabetology. And she has more than 10 years of teaching experience. Next, we have Dr. Jyoti Pathania, who's a professor anesthesiology IGMC Shimla. And she's the president of ISA Himachal Pradesh and a reviewer of reputed international and national journals. Then we have Dr. Gauri Arora, consultant anesthesiology, Aurora Hospital, Nagpur. She has an interest in pediatric anesthesia, regional anesthesia, and anesthesia for laparoscopic surgeries. And we can see she has a lot of awards and achievements in her kitty. Then we have Dr. Raghunandan, head of Department Emergency Medicine, whose area of interest are regional anesthesia and critical care, and he's the team leader, next generation anesthetists.
Next in the line, we have for the clip series, Dr. Lam Gopalam Chauba Singh. His areas of interest are focus and regional anesthesia, and at this present moment, he is Associate Professor of Anesthesiology at RIMS, Imphal, Manipur. Welcome on board, Dr. Chauba Singh. Next, we have... Thank you so much, Dr. Manoj Kumar sir. With profound respect, I hand over this particular mic to Dr. Ranju Singh, who is the current moderator. Please, ma'am, take over the proceedings.
Thank you so much, Dr. Mayank, for all the introductions you've done. We'll not waste much time, but jump right into the topic. We are going to discuss the relevance of perioperative investigations in our practice. Now, whether we are in an institutional practice, whether we are associated with the corporate world, whether we are doing individual practice.
Dr. Ranju, just 1 second.
Sir.
We welcome our very senior person, the academic chairman of our society, Dr. Venkatagiri sir.
Right.
Just 1 minute, break.
Yes, yes, please, please.
Giri sir, welcome. You can unmute yourself. You can unmute your now. Giri sir, unmute.
Okay, thank you, Dr. Bajwa. Good that somehow I saw that and I could not attend the last one. Would that clinical practice series for the practitioners, it's good that more practitioners join, and in the not so ideal condition, what depth we can do and how much we can do, and that's what the practitioners have to learn. The best thing possible. May not be having the most ideal conditions and all, but what best and what is the minimum and most ideal, they should know that. That I think this will enlighten practitioners that what they have to do and what should not do. Thank you.
Thank you so much, sir.
Dr. Ranju, continue, please. Sorry to interrupt.
No, absolutely okay. So we are going to touch upon an area which affects all of us, irrespective of our area of practice, corporate world, institutional practice, medical colleges, individual standalone practice. We have to anesthetize patients and we do have to see them preoperatively. Now, exactly what is the relevance of these preoperative investigations, how we go around doing them? We'll be discussing with our esteemed panelists today evening. So let's begin with first establishing what is the relevance of these preoperative investigations. Why should you actually do a preoperative assessment? Is it of any benefit to us? Does it really help in improving the patient outcome? So let's hear what Dr. Chauba has to say about why actually a preoperative assessment or investigation is necessary. Dr. Chauba.
Thank you, ma'am. Good evening. So, like preoperative assessment, is very important. So it develops between the doctor and the patient. It really helps to understand the patient and doctor. The relation is important, number one. And number two, after establishing the relation, we have to know what all the patient has got, what all the condition has got. So if there is any disease or not, any relevant history which is directly going to affect the patient management, NSM management in the operation time. So all this we have to identify, and if possible, we'll optimize the patient and we'll do the risk assessment. If there are comorbid conditions,
right,
any other thing are there, so risk assessment is there. And above all, so we need a consent. So we have to properly tell them the consent and what the planning of the patient, planning of the NSS. We'll discuss with the patient. So right, that's why we need to know the pre-op NSS checkup properly.
Right. So you are of the opinion that not only does it help you identify the patients with comorbidities, but helps in risk stratification and eventually optimization of these patients, which probably will help in a better outcome.
Yes,
right. So Dr. Raghunandan has a slightly different practice from what I'm aware, deals with a lot of rural patients and is not in an institutional based practice. So Dr. Raghu, would you like to tell us in your kind of setup, do you also feel that all these goals are met by doing a preoperative assessment, which Dr. Chauba has just outlined?
The fundamental basis for our purpose of preoperative evaluation, PAC, we have to get an information about the patient's condition, whether the patient is having any comorbidities or he is on any medications. And we can get a detailed history by doing a clinical examination, ma'am. Whereas in our rural setup, actually what happens is we get in a very primitive state, the patient's reports, preoperative reports, if possible, a physician advice, ECG and other chest X-ray and other things. Whereas to optimize the outcome of the patient intra-op and post-op, what I would like to do is what we are doing in an institution, ma'am. Usually we do a pre-anesthetic examination, which is done at least 1 day before the elective surgery, where a detailed clinical examination is done, where the airway assessment is done, where the clinical examination of the different systems are done. And if needed, we will advise for the pre-operative investigations which are needed for as per the ASA guidelines.
So according to you, your pre-operative assessment is an amalgamation of history taking as well as targeted evaluation of the patient physically and followed by a certain set of investigations. So, sometimes we jump on to investigations. Do you think these investigations which are ordered are actually covering up for faulty examination and scarcity in history taking?
Ma'am, actually what happens is if we adequately give time for proper clinical examination and examine to the minutest points needed for our anesthetic implications, we can take care of the shortcomings of PAC, ma'am. Usually what happens is the anesthetist, because of the surgeon pressure or because of the time pressure, what happens is we usually skip on to the things and rely mainly on the pre-operating investigations, which is not a right procedure according to me.
So you do agree that occasionally we are bypassing this history examination bit and jumping on to the investigations. Is that right?
That's true,
so
that's
in your kind of setup, who is actually doing this history examination? Whom do you relegate it to? Is it the
usually the first clinician who sees at the periphery would be the surgeon or the person who is a physician, ma'am. We rely on a rural setup usually on the surgeon's history, what he has given, and whatever has transpired during his examination with the patient, ma'am, and correlate with the investigations.
So you are relying on the examination findings of the surgeon.
Yeah, that's true, ma'am.
I am sure Dr. Karthikar must be very happy to hear this. He's the only surgeon amongst us, and I'm sure he's going to relate this to everybody when he goes back, that he plays an important role in the scheme of things. What about Dr. Choba? Do you think the history examination is being done properly, or do you think we are skipping it most of the time and just relying on a set of investigations?
No, to tell you frankly, now the clinical touch is reduced a lot. Like, see, like to count the pulse rate. See, people put the PGT, put the pulse oximeter and see the rate. So touch of the patient, radial artery, volume, then your rate, rhythm, everything was lost. I'm just giving an example of the your pulse examination. So we tend to rely more. I think now the trend is more of the investigation and more of the
more on the investigation. So who is the person who does all this history and examination?
No, actually what happened was I'm working in a testing institute. So my PGTs used to go, the first year PGT and second year go. That they usually see the patient 1 day ahead of the surgery. Or we have got a PAC clinic is there. So 1 week before that, they'll come there and we'll try to stabilize it. So usually, first year, second year, usually goes it, they'll report to us.
So probably in an institution-based practice, it is the resident who is the first point of contact. And probably in a corporate sector where you have less residents available, maybe it is the consultant who goes and sees the patient first. And the person who's probably giving anesthesia is different from the person who's examining the patients. That also sometimes happens. So Dr. Raghu mentioned that occasionally it's the physician who refers the patient, who may be the first point of contact. So Dr. Sri Vidya here is an expert from internal medicine. So does that happen with you, ma'am, that you are the one who's seeing the patients for the first time, even before the anesthesiologist has seen them?
Definitely. Good evening, everybody, and thank you very much for having me here. It's an honor to be among anesthetists. Usually, physicians and anesthetists are at loggerheads, especially when the surgeon is sitting on your head to get the patient operated. we do see a lot of patients who have not been seen by the anesthetist, especially when these patients are high risk category. Say, for example, they have multiple comorbidities, and initial investigation panel will show that their sugars are high, the blood pressure is not under control. Then there's no point in there even going ahead with the anesthetic check when we already have a lot of stop gaps to full. So we do see a lot. In my 20-25 years of practice, I've realized that when we have a better control of your comorbidities, we are definitely bringing down the surgical the surgical risk, or the outcomes are better. If I mean, that's my take on this.
Okay. Okay. So probably in a certain area where you have larger institutions, you have facilities available, expert consultation is available, or occasionally when you are referring patients, you may be the first point of contact, or sometimes the surgeon is the first point of contact. So they are the one who's doing the history and examination before actually the patient comes to the anesthesiologist. And even when we are seeing the patient, there's a wide variation in whatever is happening in different parts of the country. Occasionally, the patient is put through the PSC clinic. It may be days or weeks before. Occasionally, it's somebody who sees them an evening before. Somebody sees them early morning. It may be different for admitted patients, different for patients who are coming for outpatient surgery. So there's a very wide diversity of situations within our own setups. So why is that happening? Dr. Jyoti, what about your kind of setup, and why do you think we have such a wide variation in our PSC practice in our kind of setups?
Good evening, everyone. The PSC checkup in my institution, which is a tertiary level institution in the hilly terrain area of Himachal Pradesh, is generally done in pre-anesthetic clinics that we have. So it is generally done 24 to 48 hours prior to the surgery, and the surgeons refers the patients to us. And in only 10 to 20% in clinics almost a week before, because they are not sure whether these patients should be admitted, the PSC is done a week ahead of surgery. But in any case, the guidelines say that the PSC has to be repeated in such scenario also at least 24 to 48 hours prior to the surgery. And it is done on the day of surgery only in my institution for emergency patients who are coming for the operations, because we don't have daycare surgery scenarios. Because of the hilly terrain, the patients cannot come in the morning and get all the investigations and be operated upon. So the diversity is basically because of as I've already said, the terrain is different. The type of surgeries are actually different, because the patients cannot come in the morning and get everything done. So in my scenario, it is done 24 to 48 hours prior to the surgery in most of the times.
So, Dr. Karthikar, when do you refer your patients to the anesthesiologist? Do you get them investigated before you refer them, or you look at the anesthesiologist for prescribing a certain set of investigations? What is the practice and what is the general view of the surgeon before he sends a patient for the PSC?
Good evening, and thank you for having me here. I look towards the pre-anesthetic checkup as I would like to give an analogy that all of us, we have heard that we have got brakes. So everybody, if anyone is asking, why do you have brakes? What is the use of the brakes? So people say to make the speed less, to avoid the accidents, to stop at emergency. But I have been told, or I have been taught, that the use of brake is to increase the speed. So we imagine if you don't have brake in our vehicles, we would not dare to get any speed. So the anesthetic checkup, I feel, is a brake which increases my speed to operate the patients. And once I start looking at it from this angle of view, so all my irritation and all these things, they vanish, because it's a mandatory thing for me. Though I am working in my hospital, which is a tertiary referral center, but I also go to the other orthopedic hospitals, other general hospitals, where I have to treat. They are like nursing homes. There, Unfortunately, I'm sorry to say, the pre-anesthetic checkup on a day earlier is not done. So the anesthetist is informed that this case is being returned tomorrow. These are the investigation done. Then just 10 minutes prior to that, he may come and see. And so these are the only ways in which the cases may be postponed. But I think it is absolutely mandatory for the benefit of the surgeon and the patient that a thorough pre-anesthetic checkup has been done and it has been done properly. Once that happens, then there is no issue of cancellation of an elective case. About emergencies we can think about, but whenever we are doing an elective case, if a proper pre-anesthetic checkup has been done, then there is no need of cancelling. I think I haven't seen in my hospital that an elective case being postponed unless the patient throws something. But
it's so heartening to hear this from a surgeon, and I think it's years of experience which tell you how important your anesthesiologist is. And I'm glad he said the PAC is a break and not the anesthesiologist is a break. So what about freelance practice? Dr. Gauri probably has a large freelance practice, and she deals with a lot of cases who probably come to her on a daycare basis. So what is the practice for PAC at your institution, Dr. Gauri?
Actually, yes, you are right. Most of the patients are coming to me as daycare surgeries. We get patients, they come NDM only as they are referred from the peripheries. So I do the PAC on the same day and get the lab test done, or if certain investigations are required, the patient needs to be optimized, stabilized. So we post them the next day. So it is almost the same day thing. But earlier I have worked in corporates. There we used to go and do PAC the previous day or say 1 or 2 days prior. So and if like patient gets, sometimes patients, they get the cases fixed up on phone itself. So especially the pediatric patients. So in that case, I make it a point to make a video call and talk to the patient's mother or somebody and ask about the history, especially because the physical examination definitely cannot be done. So I ask about the relevant history, and then we order for the investigation. And
so who has seen these patients when they come to you? If you're seeing them on the day of surgery, you mean nobody has actually seen them before? They've been referred to and you see them for the first time on the morning of surgery?
Yes, it's me, because now I'm having my own setup. I'm working in my own setup.
Okay.
So I'm the first one who sees the patient.
But as you're saying, if you take a history on the phone, you can't do an examination on the phone.
Exactly.
So you just have to rely on the history and assume that whoever is giving the history knows, the details about the patient's important events, so that they can give you a reliable history.
Yes.
So what
Mostly
happens?
I talk to the mother.
So what happens when you see the patient in the morning and you realize after you've done your history and you've done an examination and you realize there is a finding which nobody knew about? Maybe the child has a murmur in the morning or has a comorbidity which was not picked up. You see the patient in the morning and he's obese and probably has a history of OSA. How do you proceed further? Because at that time you've done your examination, the patient is scheduled for a surgery later in the day. There's not been investigated. So how do you then go about, it's the first time you've examined the patient. If you have certain findings which merit investigations, how do you go about it?
Exactly. In those cases, we will get the patient screened. Like as you said, that if the patient is having a murmur, I refer the patient to a pediatric cardiologist. I'm mostly into pediatric practice. So, and investigative work has to be done, and these cases cannot cases can only be done if there are no other comorbidities. The child is fit and not having problems like URI and all these things, which will lead to cancellation.
Madam, Dr. Raghunandan and Dr. Katikar wants to speak something.
Yeah. Dr. Raghu, please.
In case of rural practice, what I have observed is most of the time, as I told you earlier, it is my surgeon or the gynecologist who sees the patient. And most of the things are conveyed by these people to me. I make it a point to raise my concern regarding the things which are of optimum importance to me to anesthetize the patient, ma'am. let it be like the airway. I would insist on the airway photographs to be sent to me, and the investigations, and if at all the patient is above 45 years and having any comorbidities, I always insist on the physician review, physician fitness, and there is any ECG changes, we want a cardiologist opinion to be done, which takes time, or which usually makes them to delay the surgery for 1 or 2 days. But in the benefit of the better outcome for the patient and for the patient's benefit, I insist on these things to be done and as a priority, ma'am, because we do these surgeries in a rural setup where we'll not be having a backup of a ICU or a critical care unit to take care of it. And any complications we end up usually.
We will be shortly coming to that as to what exactly investigations would you want in a certain set of patients.
Okay.
And Dr. Karthikar wanted to say something.
Ma'am, I thought you asked Dr. Gauri ma'am about the daycare, the daycare patients.
Yeah.
So what I would like to say, the daycare is to avoid the expenses for the patient and for the insurance companies.
Yes.
So we are not admitting patient beyond a day and we are sending them home that day. That's right. That's absolutely correct. See, I am not examining the patient on the same day and posting on the same day and doing it. The patient is coming to me earlier. I am examining him. I am getting his investigations done. And then I am advising him surgery. Now, once he has agreed and I have given him for appointment, in my neuro, there are very few patients, but the spine patients and the carpal tunnel, they come like that. But we make it a point that when the patient has agreed for the surgery, we tell them, you need to get a pre-anesthetic checkup done.
Okay.
So as he has seen me, he has to see my anesthesiologist. Okay. And once he gives okay, then only the daycare will actually function.
Right.
A patient is coming as a novice without any investigation in the morning, then it may not be possible for me to do all the investigation, then see them properly, then we get some surprises. So once the pre-anesthetic checkup has been already done, so that I think is the spirit of daycare surgery.
Absolutely. So that brings us to this very important point as to what is the optimum time for actually doing a PAC. You know, we are talking about a history and examination. We are talking about the physician seeing the patients first. But in the ideal situations, what is the exact time you would like to schedule a PAC? Is it weeks before, a couple of days before? You would be fine seeing the patient a day before surgery. What is your opinion, Dr. Jyoti? Dr. Jyoti?
Ma'am, can we proceed to anybody?
Yeah. Dr. Chauba, what do you have to say about optimum time of actually doing a PAC?
Actually, in my hospital, what we do was there. So
your audio is not very clear, Dr. Chauba. I don't know if the rest of you can.
Hello, can you hear me, ma'am?
Yes,
yeah, better.
Yeah. So actually in my institute, what we do was we usually go to the PAC clinic first. Most of the elective cases and major surgery, they usually go to the PAC clinic. It might take weeks or 2 weeks, 3 weeks. Then that is one. And if the PAC clinic cleared the patient, with the PAC, they'll do a brief borderline thing. If they clear the thing, any referral, any optimization, they try to solve the problem at the PAC clinic. If it is
okay.
If once it's clear, they'll be admitted to the ward. Then 1 day before the surgery, they'll put up the thing and we'll go and see the patient. This will be done by the anesthetist who is going to give the anesthesia.
Right.
That is the thing we usually practice in my
setup. So what about your setup, Dr. Jyoti?
It is some way similar, Dr. Ranju. We are seeing the patient in PAC clinic once the patients come to the OPD for checkup to the surgeon. The surgeon, after seeing the history and other things, decide whether this patient needs a pre-anesthetic checkup prior to the surgery or not. So they refer it to our clinics, which are situated just next to their OPDs. So we see the patients, we write few tests if they are required, because the crux of all pre-anesthetic examination lies on 90%. It has to be on the history and clinical examination only, because if the patient is asymptomatic, the role of investigation is negligible. So unnecessarily, all the investigations have to be avoided. But if we have seen the patients, we have in a way formed in our minds what we are going to do to this patient if this patient comes to us a week later. So in my institution, they're coming prior to the surgery, and 1 day prior to the surgery, as Dr. Chobe has already said, we are re-examining them because that is what the guidelines say.
Okay. What about you, Dr. Gauri? When do you actually think that the PSC should be done? And in your kind of setup, when is it really done?
No, at least 1 day prior it should be done. I agree. In fact, it is better if we can do it a couple of days before so that we can optimize the patients if there is any deficiency.
Okay.
But in my kind of setup, as I said, most of the times I get patient in the morning or just 1 day prior. So, and if there is something which really needs to be corrected and it would take time, then we postpone it definitely.
Right.
Unless until the patient.
Right. So in my kind of setup, I come from a large institution with so many postgraduates and residents. So that's the general practice in larger institutions, that the patients have to go through a PSC clinic prior to getting dated. That means the surgeon sees them. He is the one who advises a battery of investigations depending upon the patient's physical status or his comorbidities. And then the patient comes to you in the PSC. Once you see him in the PSC and give the clearance, only then the patient is scheduled for surgery. And as Dr. Karthikar is very rightly pointed out, all the patients who come for daycare surgery are actually seen by the surgeon many days before. Only then he schedules them for a particular day's care surgery when they have to come in the morning. So there is plenty of time for the patients to get seen by the anesthesiologist and if required, get investigated. So in all this sequence, occasionally, I think institution-based practice, we also see the patients 1 day prior. And in fact, it is that day where the person who's actually going to anesthetize the patients ends up seeing the patients, because once the OT list is out, you know what is on your OT list tomorrow. You can go and see those patients if they have been admitted, or at least discuss with your patients if you've seen them before as to these patients coming in the morning of surgery. I think, as Dr. Gauri has said, even if it's a daycare surgery, she does examine them before, she gets investigated. In all this sequence, when you see your patients 1 day prior or see them in the PSC clinic and they end up having a comorbidity, either based on history examination or sometimes with investigations, how relevant it is to refer these patients to a physician. For example, the patient has hypertension or diabetes or has any other comorbidity. Do you think all these patients, for medico-legal reasons or other reasons, should be seen by a physician, or the anesthesiologist has seen them and that's enough? So Dr. Vidya, what is your opinion? As a physician, do you think you should be the one who should be advising all the optimization, all the medication prior to surgery after the PSC has been done?
This is very straightforward, actually. You know, we don't have to reinvent the wheel. If the anesthetist feels on PSC that the sugar is under good control, there is no anemia, there is no hypertension, the patient is essentially walking in with a clean bill and is a person who's been on a regular follow-up with their previous physician, then probably the maximum in today's scene we will do is check whether the aspirin is down or the anticoagulants are not there, and we go ahead with the surgery. I have been working with corporates for the last 20 years, and we always work in tandem with the anesthetist. These patients who need more than, say, for example, this surgery cannot be done if my patient's COPD has not been, medication has not been optimized, blood pressure has not been brought down. Let us try to bring down the sugar under control. Then this is where the physicians should come in, because what am I otherwise going to add to a well-balanced prescription? It is wasting my patient's time, money, and energy. So I would rather that the anesthetist takes a call. If they need, we are always there. This is the way I work. There are certain conditions wherein these patients are admitted with the physicians, and then we suddenly realize that this patient needs surgery. It may not be an elective procedure, or maybe an elective, the patient has come with a high-grade fever and we realize that there's an abscess. and diabetic foot patients and all. This is where we need to kind of optimize the patient regimen and then hand the patient over to the anesthetist. So it works both ways.
So you would be like to involved in that optimization of these patients?
Absolutely, absolutely.
So suppose you have a patient who comes to you in the PAC, say with, you examine him and you find that he's hypertensive. So do you think the anesthesiologist should be the one to start the antihypertensive medication, or should the patient be referred back to you for starting that medication?
Depending upon the emergency, depending upon the need of the
it's
surgery.
an elective surgery. We are currently talking about an elective surgery.
Yes.
The patient is for a lap chole. You see in the PAC that his blood pressure is very high. Should the anesthesiologist be prescribing medication? Should he be sending it to you? You would decide what medication to give, what investigations to do or not?
Definitely. I would rather the patient comes back to the physician, because there is going to be a long-term follow-up of this patient afterwards. Short-term medications, the patients usually after surgery stop. So the way it goes is that why should the anesthetist be sitting and doing an OPD work and ensuring that the patient, that is my logic here. But well, yeah.
You come from corporate sector. So Dr. Raghu, does it happen like that in the rural sector also? Or you are the one who is left at the other end of the stick, where you are the one who's actually seeing the patient, diagnosing his hypertension, starting medication, advising, monitoring, or whatever else you are doing?
Usually, I've been in 15 years of practice now, ma'am. During my earlier days, having a physician availability was not there. So during that stage, if I come across any patient with hypertension, diabetes, I used to manage the thing, and the medico-legal implications were not so serious in that scenario, what I'm talking about. As the scenario changed, as the physician availability was there in the rural setups also. Now, nowadays, once I do a PAC, let it be a PAC related information which I have got, or I've done a PAC myself. If at all I find any comorbidities like diabetes, uncontrolled sugars, uncontrolled hypertension, or if there is any immunological disorder in the patient, I would ask for a physician referral and physician advice before taking up the case for anesthesia.
I would like to add one more thing here. Sorry.
Yes, Dr.
See, these are the patients who probably, like, if a patient is coming for a lap chole, the patient's blood pressure is high because there is acute cholecystitis or a stone obstruction. That is one part of it. There are certain patients who have, say, example, subclinical hypothyroidism, and for the sake of discussion, the anesthetist starts the patient on medication. Does this patient actually need medicine, or it is only for the anesthetist, for the surgical, for the anesthesia that you are giving it? A lot of cardiac anesthetists do this. Then does the patient need to continue on thyroid medicine? Does the patient need to see a physician? These are the questions which are kind of left hanging. So it is always better that if the physician is available, better keep in tandem. Legalities wise also it makes sense. But if it is not available, anesthetist is equipped to handle it.
Okay, great. So Dr. Katikar, you are the one who sends the patients for the PSC. You've seen the patient, you've decided this patient needs XYZ surgery and needs to see an anesthesiologist. So is it you who sends the patient with the investigations, or do you wait for the anesthesiologist to see the patient and then advise the investigations?
Well, actually, we have a protocol of investigations. Those investigations are done as soon as we advise the surgery and the patient agrees.
Okay.
So that battery of investigation is already done. These are the basic protocols for our PAC checkup.
Okay, so which are the investigations you advise routinely then?
These are the blood investigations like CBC, BSL, serum creatinine, serum electrolyte, then HbS-AG, HIV, then ECG, X-ray chest, and if a patient is hypertensive, then 2D echo. These are the basic things we advise for all the patients. Okay. And PT-INR, I forgot to add. PT-INR, we always do it.
Okay, so the entire gamut, see, it's all lopsided here now, because you see, we are sitting here and formulating guidelines for ourselves, where we are deliberating. We have national guidelines where we're saying you do this investigation and this patient and this in this patient and don't do this. But in actual ground reality, you get your patient after the surgeon has done the investigations. And it's according either their institutional protocol, their protocol of a battery of investigations being done in majority of the patients before they come to you, right, sir?
No, madam. I think I was not able to express. This battery of investigation or the protocol is set up by the anesthesiologist. So I have not set it up.
Okay, so that's
everywhere.
So you have certain protocols in place in your institution set up by the anesthesiologist, which you follow.
These are the PAC investigations for all cases. So that is what I am not adding anything on my own. That is what they want.
Okay. And it's not a general dictum कि ये patient इसके लिए आया तो ये सब कुछ करा के भेज दो. ऐसा नहीं होता.
Madam, whenever we are doing majority of our patients under general anesthesia, so this is the standard protocol we are following for all the patients.
Okay. What in your view, after so many years of your practice, do you actually find patients with a lot of abnormality in their investigations?
Madam,
if you do, what happens to them?
Madam, I'll take a minute to tell my own experience. When I was in training in 1990s, so at that time, while operating some head injury patient, there will be a lot of oozing. So then our chief would say, in head injury patient, there is always oozing because there are coagulopathies. You should do BT-CT PT of all the patients. So then for 1 month or 2 months, we would do it. Again, we would stop. Then again, a patient would come like that. When I came to Solapur to practice, mine is a non-metro third-tier city. So I was advising BT-CT PT for every patient. And while cutting the cost, so there was an issue. Why my patients are spending 500 rupees if none of them are coming abnormal? So I took a call that today I am advising BT-CT PT for this patient for the last time. For him, if it comes normal, then I will stop advising. I'll advise only when I have a doubt. But that patient, without any history, without any comorbidities, had a clotting time more than 15 minutes.
Okay.
And I think I got the answer that whatever is the protocol which is set up, it should be followed blindly. We try to evade some things mainly to cut the costs. But at what cost? So if we think that every patient is my brother or sister, then we won't stop this. We will do all the investigation anyway. So why not for our patients? That is my attitude now, because I had this so much in my mind that I was thinking I'm going to stop this. But that patient, 15 minutes clotting time. A spine surgery, if I would have opened up, I would have been in a mess.
Okay. So in your setup, Dr. Jyoti, what kind of investigations are the patients subjected to before an elective surgery? Say if it's an ASA grade 1 patient who is for a routine elective surgery, say lap chole, what investigations would you get the patient to undergo?
Ma'am, actually, I agree with Dr. Datta Prasanna that all the surgeons are getting all the investigation thinking that in asymptomatic patients, the screening, they are doing it for screening of the disease. But unfortunately, all the big guidelines, all European guidelines, ASA guidelines, and even Indian guidelines have noted down that the investigations are not recommended for screening of the disease, because in asymptomatic, as Dr. Saab has said that the clotting time was 15 minutes. It has seen that in asymptomatic with no prior history of bleeding, this patient would not have landed up in any additional problems had he undergone the surgery with that clotting. I would just want to ask Dr. Datta Prasanna that for his 15 minutes clotting time, what extra was done to improve the outcome?
So, ma'am, after that, he was referred to the specialist. They investigated him, they found out some cause, and he came back to me after 2 to 3 months that now that everything is in control and now he can be operated.
Sir, the clotting
time. What is the incidence of this abnormal finding, Dr. Karthikar? Does it, if you have one finding in so many years, does it justify all your patients undergoing this investigation because one patient had an abnormality?
No, madam, what I was trying to say that I was doing that blindly. when I thought ki now I should stop. And at that point it happened. So now I am continuing PT-INR because nowadays there are many patients who are alcoholics. They may not tell us honestly. There are people on ecosprin. They may not be aware of that. There are people who are having other illnesses. Our history taking, though we try and be as thorough as possible, people may be hiding so many things from us. And PT-INR now BTCT has gone out of vogue. Now only PT-INR is adequate for us to know. So it's a very simple
This
investigation.
basically reiterates the fact that we started off early in the evening that history and examination has to be done. Actually, there's no shortcut to that. A detailed history taking and a targeted evaluation of the patient by somebody who knows his being is very essential. You know, you cannot relegate this to the junior most person ke jaake patient ko dekh lo aur fir aapko aake kahani bata de. Somewhere you have to take a call that a person who is, you know, knows about the anesthesia practice should be evaluating these patients so that you can actually decide what investigation to be done in what patient.
Can I say something?
Yes, please.
Yes. So if we go through literature reading, Dr. Katikar also, you will see that I do not think in a PAC setup in the last 100 years, we have had a abnormal asymptomatic clotting time. You can go through literature. I would be rather I pick up a bleeding time abnormality than a clotting time, because clotting time patients, elevated CT, asymptomatic is practically unheard of. So I wouldn't worry about it also. I am really happy that you picked it up. Where will we suspect a elevated clotting time is when we do a routine CBC and see that the platelets are elevated. There is where my red alert will go and say, okay, something is not right, but otherwise also BTCT is out. The more PT-INR we use, we can objectively bring down the cost of that investigation, because we are able to justify that, because we are able to do both ways that way. Abnormal CT value does not have a clinical significance if the patient is asymptomatic.
No, madam, I'm sorry that I was in the heat of argument. I said we had done BTCT and both were prolonged at that point of time, and this has happened 20 years ago.
This is just one example. So it should not become the focus of the discussion.
I'm sorry to intervene. I think we should carry on.
We should not let that become the focus of the discussion.
It's the one-off thing.
In your kind of practice, Dr. Chauba, what preoperative investigations do you advise? Say it's a ASA grade 1 patient who's coming for a young adult patient coming for inguinal hernia. What investigations would you think should be done for this kind of patient?
If you see by the investigation depend on the whether it's elective or the emergency or semi-emergency. If it is elective,
elective young adult male for inguinal hernia, say.
No, that is like not a very complicated surgery, intermediate type of surgery. We won't be requiring much of the investigation if he doesn't have any clinically significant history. If it is not there, so simply one CBC might be enough. The KFT, I might not do it if it is young. So we know that if it's not non-diabetic, I'm not going to do the creatinine again. The LFT, I don't think it's required. But the urine RE is totally no for me in the coming for the thing. Urine is another thing people do lots, but somehow urine is something which I can't come to the thing from an NSA point of view. And then the ECG being the type of surgery is very low risk or surgery, so we can go for the without ECG. X-ray, non-smokers, I won't do it. So ultimately it'll be mainly the CBC.
So probably the only investigations you want to do for this patient is a hemoglobin or a hemogram. That is all?
Yeah,
blood count. Complete blood count.
Okay. And what about you, Dr. Gauri? If this patient came to you for an elective inguinal hernia repair, what investigations would you like to do?
See, this is a young patient, and hernia repair, if we categorize, it comes into intermediate category. And as per the ASA guidelines, preoperative guidelines, for intermediate surgeries, In a young patient, a CBC is required, a serum creatinine is required. Naturally, young patient means must be below 40, 45. So we will not do an
Yes,
ECG also.
maybe 28,
But it
30,
is a-
32 years.
Yeah. So we will not go for an ECG or an X-ray. But this patient is for hernia repair surgery. So maybe the surgeon would like to get a blood sugar done so that there is no infection. And yes, I would like to do a urine analysis because UTI, if present, if there is suggestive history, then this urine examination should be done because it will, if the patient goes for urination frequently, it will put a lot of pressure on his hernia surgery site. And also a KFT if required, if patient is having UTI.
What about the coagulation profile?
This patient doesn't
Coagulation
have
profile,
anything. He has no comorbidity. So still you would like to get KFT done?
Madam, it is a recommendation of ASA, preoperative guidelines, that for an intermediate kind of surgery, you do a CBC and a KFT if it's a young patient. So these two definitely I'm going to do so that I can safeguard myself from medico-legal point of view.
Madam, just a small, I'm sorry to interrupt.
Yes,
just
yes,
a
please,
small
Dr.
change that has happened post-COVID era. There are many patients in the young age group also coming up with certain like undiagnosed diabetes. Has the investigations profile changed post-COVID era in many of the institutions for this intermediate surgery also?
Dr. Gauri, would you like to answer that?
Sir, about the institutional protocols, I'm not aware of. But then, as I said, maybe a blood sugar a surgeon would like to get done because it is in post-COVID era. And in COVID era, everybody knows that COVID has affected all the systems of a person who got infected with COVID. So keeping that in view, maybe a blood sugar is required, but coagulation profile, I don't think I'm going to do it if there is no such.
Dr. Jyoti, what about you?
I just want to add that our guidelines came in 22. So that was after the COVID, and there is no guideline which suggests that you should test for glucose. Testing is not recommended, be it ISA guidelines, ASA guidelines, or NICE guidelines. We are only going to categorize our patient on the basis of ASA physical status, then on the type of surgery, and then the meds and the functional classification has to be done on the patient. If by any chance patient gives any positive history, then only the glucose testing is recommended. Otherwise, sir, Dr. Mayank, it is not recommended in post-COVID area.
Right.
And actually, this will not be of help to you in medico-legal purpose, because unnecessarily testing will actually delay the surgery and can ultimately land up in further problems in medico-legal when you face, because even ISA guidelines, which are on weak recommendations, do not advocate blood glucose testing in such scenarios. So we will not be actually benefited by this.
So there are two parts to this. One, as Dr. Mayank has raised this issue about post-COVID involvement. I think majority of the institutions have realized that once we've moved away from COVID, the incidence of involvement of systems, yes, we agree is there, but I don't think many of us are doing any targeted investigations for COVID today. When the patient is for elective surgery, particularly when he's completely asymptomatic, I don't think most places are doing investigations targeted for the sequelae of COVID. So, and in this patient, as we said, this is an ASA grade 1 patient. Would you like to do a hemoglobin or a hemogram for this patient when there is no expected blood loss? If the patient has got a good clinical evaluation and he doesn't appear to be pale, is taking a good diet, is from a reasonably average socioeconomic status, it's a surgery which does not involve major blood loss. Would you recommend doing a baseline hemogram for these patients before taking them up for surgery? Dr. Raghu?
Yeah, according to the ASA guidelines, CBC is has been taken up as the primary investigation which has to be done for even minor, intermediate and major surgeries. I would like to have a CBC to be done so that at least I will have a picture about the good hemoglobin concentration of this patient. Regarding the patient good health and other things, If I'm convinced the patient is fit enough and doesn't have any coagulation problems and
on history, there is nothing available. Coagulation problem, we are talking about whether on
okay,
history
then I can take up the
examination
patient without.
would you coagulation problems will be only when you decide to investigate. This is one we are investigating, we're
Yeah, ma'am, that's
focusing on
true.
the
Yeah,
hemogram.
yeah, ma'am, that's true.
So
Yeah, ma'am.
hemogram is
But-
is that the consensus of the house? Dr. Srividya, you have to say something about doing baseline hemograms in normal patients who do not have any comorbidity, who are healthy young adults for elective surgery.
How will we know whether they have comorbidity or not unless we investigate? Who is normal today? We are looking at young adults dropping down. So I think it makes sense to have a baseline investigation, because we are not only, see, hemoglobin may be normal, but the MCV will be high. There will be underlying B12 deficiency, which is being seen in both vegetarian and non-vegetarian, so-called healthy people.
Is not part of your normal hemogram. Your normal hemogram will include the hemoglobin and MCV.
No.
And MCV.
Correct. What I'm saying is MCV will be high, which will indicate, or there may be a dimorphic anemia. So baseline hemoglobin is definitely mandated. And also the pre-diabetic condition, because that has a lot of outcome. Suppose in case his sugars go up post-surgery, the wound will get infected.
Okay. So you recommend a baseline blood sugar level for all patients?
HbA1c and hemogram, definitely yes. May not be the random blood sugar and all. Yes, but HbA1c and hemogram, yes, definitely.
There is a question in the chat box. When should we go for 2D echo for an ASA grade 1 patient?
Okay, we'll come to that. Dr. Chauba, what do you think about the glycosylated hemoglobin levels and blood sugar levels? Do you think we should do them for all patients, keeping in mind the prevalence of diabetes in our country? Dr. Chauba.
Yeah. So like I do agree that young diabetic is there, but like depending on the surgery, but if it is a major surgery, I'm definitely going to do it. But for minor surgery or the intermediate glucose, I might not do.
Okay.
We
will be projecting the guidelines of ASA for the benefit of everybody in a little while. But the guidelines which have been put forward by ISA do mention that for non-diabetic patients, a blood sugar level should not be done either for mild, moderate, or for major surgery. Now, my question at this point is, this is for non-diabetic, but how do you know he has diabetes till you actually do something? If you're not investigating, many of our patients' first point of contact is us. That means he's never got operated before. He comes for an inguinal hernia. This is the first time in his life probably he's getting investigated. We've done one hemogram and said full stop. We've not bothered to examine either his glycosylated hemoglobin or his blood sugar levels, because our guidelines say that they needn't be done for non-diabetics. So how do you diagnose the diabetic if you've never going to do the blood sugar levels? So do you think for all these patients, like we are doing a hemogram because we are, as you've said, it is necessary to diagnose anemia. The incidence of anemia in our kind of population is so high that we need to probably do a baseline level for them to diagnose. So in that context, will it not be more sensible to do a blood sugar or a glycosylated hemoglobin for all these patients, irrespective of the kind of surgery? What do you say, Dr. Gauri?
I think so. It should be done, at least for intermediate and major surgery. This is
why not even for minor surgery? Why diabetes?
In fact, the blood sugar should be done as a screening test. Because we are having many patients of diabetes these days.
Dr. Jyoti, what do you say?
Ma'am, no guidelines support HbA1c. No
guidelines we make. Guidelines are the one made by deliberation of August gatherings like these. These are the inputs which will eventually go into revision of guidelines. So
no, ma'am, they are done basically on reviewing the various well-formed studies, randomized controlled trials, and they have proven, like suppose if a patient's sugar comes out to be, fasting sugar comes out to be 128. So according to you,
fasting sugar karna hai ki nahi?
Nahi karna, ma'am, nobody. If the patient is less than 65 years of age or 75 in ESA, it is not recommended if there is no history.
No, no, no.
Madam,
And there is
we can
strictly
have
no
a-
for HbA1c. In the chat box, I'm just seeing some people are entering whether it is to be done. It is clearly, they have mentioned big no for HbA1c in asymptomatic patients. In asymptomatic, it is not required.
Diabetes hardly produces any symptoms, Dr. Jyoti.
No, ma'am, they will produce.
By
And
the
if
time
they are
it produces
asymptomatic,
symptoms,
they will not change the course of
Ma'am,
the
it's okay. What we can do is, I think we can do a random blood sugar. We can see a urine routine. If these two are coming out to be positive, then we can go ahead with the glycosylated hemoglobin.
So still random blood sugar karna hai.
Nahi karna, ma'am.
Nahi
It is
karna.
not recommended.
Okay.
It is not recommended.
Dr. Katikar, how do you investigate your patients? Do you ask them to get a random blood sugar versus a glycosylated hemoglobin to be done as initial investigation in your protocol, what it is?
Yes, I would just like to clarify that because what is happening, that you are talking about minor and intermediate.
Yes, and
I am doing
present minor and intermediate.
and I am doing only major surgeries and supramajor surgeries.
Okay.
So there comes the difference. And like we are talking about the diabetes. So I would just like to add, like diabetes and hypertension, we see young hypertensive intracerebral bleeds. Hypertensive intracerebral bleed to occur, the patient has to have very high blood pressure for at least 15 to 20 years. Now, these patients are unaware of that they are having hypertension for 15 to 20 years. So how on history we are going to find out that he is a non-hypertensive?
Yes.
And what is my observation is that for a hypertensive bleed, who are these young hypertensive, they bleed at the age of 45, 50. So they have started their hypertension from 25 years. And in these 20 years undetected, their kidneys have already been starting to get damaged. And they have effects on multiple organs. So in a scenario like India, just by giving a questionnaire to the people and just by interrogating them, I think I will be very afraid to assume that he is non-hypertensive and non-diabetic. I would not give because many people want to hide also.
So final word on that, Dr. Vidya, you would advise a glycosylated hemoglobin for all patients irrespective of the type of surgery?
Definitely. Definitely.
Okay.
Because like I said, we live in a world of denial.
Okay, so Dr. Vidya and Dr. Gauri, and I think I myself of the opinion that yes, besides the baseline hemoglobin or a hemogram, which we are doing, a glycosylated hemoglobin versus blood sugar levels, random, that is debatable. Some form of screening for diabetes should be done for majority of our patients, irrespective of the type of surgery. Right? Do you do a pregnancy test for your patients prior to surgery, Dr. Raghu?
Well, I'm extremely sorry. Dr. Bajwa has to say something.
Yes, please, Dr. Bajwa.
Thank you, Dr. Ranju. I agree with Dr. Katikar sir also, because majority of the patients coming to our setups, whether it's a government setup or a private setups, they are detected for the diabetes first time when they reach an institution. For how long they are staying with their diabetes, how long their diabetes is. The chronological age is never being estimated.
Absolutely.
How much damage, how much arteriosclerosis of the different end organs is there, you can never assess. When they are accidentally diagnosed, I think it's a must to go for HbA1c to at least know the fluctuation of the blood glucose, not the variable or higher end of the glucose. It's a fluctuating which is more dangerous, and your anesthesia is definitely going to harm the patient.
Absolutely.
If they are on the decompensated stage, I think another 6 months, they will be decompensated from the renal tissue, from the peripheral, the autonomic neuropathy.
Right, absolutely.
Yes, and you are right in the initial beginning also that majority of these patients are not symptomatic.
Yes.
The symptoms arise when they really get
It's too late.
decompensated.
When it's already too late, yes. So since they are probably getting investigated for the first time, I think the August gathering is of the opinion that a glycosylated hemoglobin is not a bad thing to do because it will really affect the patient outcome and you're doing more good than harm, right? Do you do normally, Dr. Katikar, investigations like viral markers also for your patients?
About the viral markers, I think I'll be again the odd man out here. because all our surgeries are major surgeries. And when the COVID pandemic started, the reports have come that the complications, they do not increase by 20%, they increase 20 times. So for a spine surgery, if I have an infection rate of discitis at 0.5%, it is going to become 20%. So I am here to say that we are routinely doing RAT tests for all our patients. And in past 6 months, we have detected 3 patients who were RAT positive. Then we did their D-dimer and other tests. They were also supporting. We explained them. They went home. Out of these patients, 2 patients had not taken a single vaccination.
Right. Right.
So I think for major and supra-major operations, I think doing a RAT test is mandatory at least for next 1 or 2 years. Once it goes in the past, we might be stop doing it.
Okay. Dr. Raghu, what about your patients? Would you advise viral markers as well as if it's a female patient in the childbearing age group? Would you want a urine pregnancy test to be done routinely before they come to you for anesthesia?
Viral markers, definitely we would like to ask for viral markers if the age group is of adult age group and above. Majorly about 18 years and above, we are taking it as a mandatory to get a viral marker done.
Okay.
And for the patients who are pediatric age group, if there is no family history like father or mother are positive for means reactive for any of the viral markers, we don't usually get it done for the pediatric age group. Regarding the pregnancy test, in the age group of childbearing age group, we don't usually insist. If at all the patient has missed periods or is in the conceptional period, that time we will ask for pregnancy test. Routinely, we are not getting it done for our patients. Pregnancy test is done.
What about you, Dr. Gauri?
I'm extremely sorry to intervene in between, ma'am. Even if viral markers are negative, you have to take universal precautions. This is a very important message by Dr. Venkat Kiri, sir.
Yes, yes,
So,
absolutely.
Because in the window period, it is not possible to get.
See, that is true for every anesthesia which you are delivering, whether minor or major, for a young, old, adult, child, everybody. You cannot circumvent the universal precautions irrespective of the type of patient or the type of surgery. So that is good anesthesia practice, and that's what keeps you safe. But having said that, are you still subjecting your patients to get in this evaluation, Dr. Gauri, viral markers and in young adult patients who are childbearing age group pregnancy test?
Secondly, is consent required for the viral markers?
Yes.
Yes.
Yes, it is. It is. Similarly, for a pregnancy test.
No, in the childbearing age group, definitely we have to keep that in mind. But then in that case, I ask the history of a missed period or the contraceptive status. So if there is any suggestive history, then I go for a pregnancy test. Otherwise, routinely, no. And as far as viral markers are concerned, they are not suggested in the ASA guidelines, but then practically it is being done for at the intermediate and definitely for the major surgeries. Yes.
What about you, Dr. Jyoti?
Maybe for the minor surgeries, one is not.
Ma'am, for the pregnancy, the same guidelines. If the patient is of childbearing age and has missed a period, then we go in, but with an informed consent. And that is what the guidelines are for ASA and NICE guidelines and Indian guidelines also. And as the sir has said about COVID testing, but I just want to add that the National ICMR has done purposive COVID guideline testing strategy, which they have issued in Feb this year. They said asymptomatic patients should not undergo COVID testing. Even RAT and all, they have clearly written in big lines that it is not indicated. It is only indicated in severe respiratory infections in patients. And even they have said that no emergency surgery should be postponed for the want of these tests. and the patient should not be shown or referred to another institution for these tests if required. And if in the same hospital in a week, these tests, if done, should not be repeated again for if the patient has to undergo. So ultimately, sir, we have to follow ICMR and our health guidelines before we, and so in my institution, we are not getting these tests done routinely in the RAT test or the COVID test in our institution.
So the RAT test is actually obsolete because negativity in a symptomatic patient does not rule out COVID. So it can be so many other things. Positivity does not make this patient COVID. So it is totally out. We do not do RAT at all. And RAT can be done by anybody. So basically, if the patient is symptomatic, needs an emergency surgery, whether he's COVID or not, the surgery has to go ahead. We have to look at other comorbidities and other risk factors. So it is not stopping. In case there is a transplant is the only place where we work. So what we do is we check for their antibody level. We can check for both the post-COVID IgG antibody and SARS-CoV-2 post-vaccination antibody to see adequacy of their immunity. And if they are good, we are clear. We don't need to worry about even those few COVID positive patients. So we are very clear about the guidelines.
Okay. So that is the general consensus that they would not be routinely done. And regarding the pregnancy test in childbearing age group, do take a detailed history from your patient if she's missed a period. And because the potential for harm is there. And a consent and an explanation that there can be harm if anesthesia is delivered to the pregnant patient, particularly in the first trimester. That should, I think, be a routine for all patients in the childbearing age group. Do a pregnancy test if she's missed a period, and if there is probably any other indication. Otherwise, and of course, as Dr. Mayank has again pointed out, consent for the same is mandatory before you go and proceed for the pregnancy test. So what about other tests like probably LFTs when we are saying serum creatinine or urea or serum electrolytes? Dr. Chauba, would you recommend these tests? When and how?
Coming to the
KFTs, because you had wanted to do KFT for your patient who had come for that inguinal hernia. So what about the KFTs? Would you like to do them? Which patients? What category of surgery? How do you go about that?
So depending on the type of surgery, the intermediate and the major surgery, so definitely they'll go for the serum creatinine. Other than that, those patients who are on medication, like diuretics, digoxin, maybe like chemotherapy or some like steroids. So we'll be doing the electrolytes and the creatinine. And another thing, those patients who are on diabetics, I'll go for the your KFTs and the type of surgery. If there is going to be lots of tissue, handling, lots of fluid shifts, lots of blood product to be required, definitely we'll go about the KFT. And any condition where there might be risk for AKI, if we thought that patient might develop AKI, nutritionally poor patient, everything looks fine, but is a nutritionally poor, weak patient, even though it's very young, definitely I'll go for the KFT.
Okay, so you would probably do it for all major surgeries. You would like to do it where you are suspecting a high incidence of AKI, where there's a lot of tissue handling, hemodynamic compromise, or if you think that the patient is on drugs which could alter his renal function status. What about the LFTs? Dr. Raghu, what about routine LFTs for elective surgery?
For elective surgery, minor surgeries, we usually don't ask for any LFT to be done, ma'am. Intermediate surgeries where we can expect any kind of blood loss, where there is an anticipation of any shift during the surgeries, tissue handling and other things, we would like to ask for LFT. And any baseline history of jaundice or any other infections related to the liver, I would definitely ask for LFT to be done. For intermediate and major surgeries, LFT is a must according to me, ma'am, because we are dealing with the duration of the surgeries and the hepatotoxicity of our drugs, especially the anesthetic agents. We should have a baseline LFT to be done before taking up patients for major surgeries.
Okay. So there is less ambiguity as compared to the baseline hemoglobin or as compared to the glycosylated hemoglobin. We are fairly clear as to which patients should be investigated further regarding their LFTs and KFTs. What about an X-ray chest and a baseline ECG, Dr. Gauri?
X-ray chest above 50 years of age in intermediate and major surgeries. This is according to the ASA guidelines again. And an ECG for intermediate surgeries below more than 45 years of age. And for major surgeries, all major surgeries will do an ECG.
Right. So for all major surgeries, yes. For otherwise, you would like to have an age cutoff for both ECGs as well as X-rays, because they really do not add any significant. See, whenever we are talking about investigations, must be very clear about whether the outcome would be different or not. And even if you have an abnormal value, will it really change your course of anesthesia? If you have XYZ abnormal value on your on your investigations, does it really change your plan of anesthesia? One of these questions which comes to our mind very often is when you diagnose that the patient has eosinophilia. Now, normally these days we have auto-analyzers. So instead of just getting a hemoglobin, we get this huge printout where every possible test has been done under the garb of a hemogram. And we look at the report and realize that the patient has eosinophilia. Now, does that have any significance as far as the patient's outcome is concerned? I'm sure Dr. Vidya will enlighten us as to the seriousness of eosinophilia, whether it actually has an adverse outcome. Should it be treated? Should the patients be continued and sent for surgery? Should you hold them back? What is your opinion? Enlighten us about eosinophilia, Dr. Srividya.
I'm sorry to intervene in between. A few special comments by Professor Dr. Naveen Malhotra, sir.
Yes,
ECG and X-ray chest are recommended with age more than 50 years, major surgery, cardiac pathologies like ischemic heart disease, septal defects,
Yes.
and LFT in the case of major alcoholics, HIV, HBsAg, HCV positive, and in the case of age more than 50 years. And there is a question regarding HbA1c that if it comes out to be suddenly positive, by Dr. Venkat Giri, sir, what next in the case of elective thyroidectomy or what next in the case of an emergency surgery? How will you proceed?
I think Dr. Vidya should be able to answer each one of them one by one. So let's finish our eosinophilia a little bit, because that is something which always confuses me also as to what should happen when a patient, you discover that the eosinophil count is high.
So Indians, by geographical and the amount of helminths we harbor, up to 10% eosinophil on a CBC asymptomatic can be overlooked easily.
So instead of the 6% abroad, you would be willing to accept the 10%, right?
Yes, yes, okay. But what we are seeing of late is that there are a lot of reactive eosinophilias.
Right.
So we do correlate, especially if there is a history of wheezing. Then we need to check out whether the patient has any reactive airway disease. The second is use of any drugs in the recent past. If you look up, you will see that these patients have been on probably on antihypertensive. So all ARBs increase eosinophils, anti-epileptics increase eosinophil levels. So a very detailed history taking about the type of geographical location, this medication history, drug history goes a long way. Outcome wise, if the patient has a history of chronic lung disease and the eosinophils are high, we need to bring the eosinophil down, optimize the medication, and then take the patient for an elective surgery. Because we see that what is triggering post anesthetic is the eosinophilia level is going up, it is doubling. We had one young girl who came with a COVID-like history, like a ARDS picture. And we found that she has primary hypereosinophilia syndrome, which has been missed in her 14 years of life.
Okay.
She has undergone tonsillectomy. She has undergone at the periphery level. Then we did a bone marrow, and now she is on treatment for this.
So what is the cutoff total eosinophil?
Anything about 10% needs to be investigated in Indians. That is definite.
So
6
there
to
is a
10%
potential-
is a bigger margin. Yes.
Okay, so that means you are saying that there is a potential for harm, particularly under anesthesia, where you can trigger reactions, you can have bronchospasm, you can have other, and these patients, if discovered, should definitely be treated. You are of the opinion before they can be taken forward.
Depends upon the emergency of the surgery.
Yeah,
You
we
can
are
start
talking
them
about
on.
elective. See, all this is with the elective surgery. When you have time in emergency surgery, you anyway won't have time to treat. So, would you advise routine antihelminthics to all patients, or
diethyl carbazine?
After high count, or would you investigate them further and withhold the antihelminthic till you discover a cause for the eosinophilia?
So first is we just give a routine round of antihelminthic and a DEC, makes sense. And we recheck in 2 weeks time if it is not going down, because most of these people would have had a helminthic thing and
so that
infestation.
Is the teaching which has been going on for so many years from my residency days, that if you have a high eosinophil count, usko albendazole khila do, uske baad sochenge. Pehle, give him an antihelminthic and then wait and see if it comes down, well and good. Otherwise, then you investigate them.
There are two things in this. One is if your total count is within normal, that is your total counts are normal and you have a relative eosinophilia, you do it. But if your total count is low or if the total count is high, definitely mandates a hematology visit, because we may be overlooking a subleukemic leukemia, M6 variety, or a leukocyte reaction. Both can be there.
It's an indicative of something more sinister lurking there. You need to pick it up and just not ignore this finding, because it is not causing any obvious harm. So as is the question in the chat box, we can answer that right now. What about a glycosylated hemoglobin, which is abnormal?
Sorry to interrupt, ma'am.
Madam, Dr. Bajwa.
Sir, Dr. Bajwa, please.
Yeah, ma'am, thank you. Actually, the cutoff value, it may be as 10. But when you go through the Harrison, the first chapter of that is systemic manifestation of a disease. So eosinophilia is not just taken as an helminthic disease or something, or leukocyte reactions or a leukemia or something. There can be more than that. So the patient coming to you with a 7% or 8%, maybe in the beginning of a new infection, or it's a manifestation of a beginning of infection. So you have to investigate that patient rather than going just for the cutoff things. You have to go deeply into those things to investigate the particular disease. Giving albendazole or antihelminthic may not sometimes suffice. Second part was the age category that particularly came up, because I am discussing so that those questions should not be forgotten.
Yes.
50 year is not a cutoff age. There is nowhere guidelines are written the 50 year, because the trend has shifted towards the left.
Lower.
If you ask me, a 30-year-old patient is coming with MI, 35-year-old with a massive collapse of the heart. There are so many other diseases which has shifted their curve to the left-hand side of the graph, so that there is no age limit nowadays with the medico-legal implications coming to you with so much of resource challenge scenarios in the peripheries. If you think that this is the age, we should have a minimal investigation at this age only. I think we are fooling ourselves, because every life is precious. We should go for the investigation in these type of patient also, because they may come to you as asymptomatic, but suddenly they will collapse on the table, and then I think we may not be able to resuscitate them. So these things, I think that's why these type of clip discussion, the crisp discussions are very important. You mentioned in the beginning that it is the beginning of a formation of guidelines. This August gathering is the beginning of such thing. So I think by the end of this clip series, we will be able to stimulate that part also. Thank you.
Thank you so much for highlighting that, Dr. Bajwa, that yes, Dr. Srividya has also said the same thing. Do not ignore an obviously raised eosinophil count. Do investigate the patient further, because you may miss an important condition which the patient may be suffering from. And we've all highlighted and all experienced the value of ECG detecting heart disease. And should we be doing it for all patients is a question. Secondly, what happens when you diagnose an abnormal ECG? Dr. Vidya, many a times the patient is asymptomatic. He comes to you, the BP may also be normal, and you have ST segment changes, or you have a T-wave inversion in these patients. So what are the benign ECG changes that we should be aware of, and when should it raise a red flag?
So mostly these changes are, if we want to look at it as benign, will be seen in women who are premenopausal. Say, for example, they're going for hysterectomy and you see that they have some subtle T wave changes or sinus arrhythmia. So I wouldn't really worry about it as long as they are between the normal, they are still in the sinus rhythm. That means in 60 to 100 sinus rhythm. Where does it flag off? Is somebody hypothyroid with a fast ventricular rhythm or a fast atrial? So we need to remember that, okay, a hypothyroidism can trigger a atrial fibrillation and an atrial flutter, especially when the patient is going for surgery. So it makes sense to get an echo done. It makes sense to see a longer strip just to ensure that we have ruled out all these things. The other is the electrolyte imbalances. What we are missing out is the young adults. This is a very, very big target zone. The pediatric age group, I'm sure Dr. Gauri will agree with me, is being very beautifully monitored by the pediatrician. We pick up on all their cardiac problems. The kids between the age of 14 to 18 who neither fit into the pediatric nor into the physician are the no man's land where we are missing, especially with the stress, increased caffeine intake, smoking, drugs, where we are missing out on any child who is suppose coming for a tonsillectomy or coming for a hernia or he's obese. There is a family history of sudden cardiac deaths which has not been explained. This should be the red flag that we need to check and get a cardiology opinion just to ensure that we are not missing a potential cardiac problem in these children. This goes on till the age of 35, where after 35 we know, okay, yes, they are prone to heart attacks, they are prone to cardiac problems. ECG abnormalities, say they have suddenly you are finding a new right bundle branch block. If they are asymptomatic, the echo shows mitral regurgitation, we are good, we are safe. But we cannot afford to just miss it because it can trigger a sudden cardiac event, which could have been potentially averted.
Madam, you said hypothyroidism. What is
That
the
means,
level of PSH?
Just a minute, Dr. Mayank. So that means you would be advising an ECG for all patients? As Dr. Bajwa has also highlighted that we have so many young deaths, there's so much stress, the hypertension has become like a rampant epidemic. So would you like to have, like we've said about glycosylated hemoglobin, would you like to have a baseline ECG for all patients now? You are highlighting that age group of 14 to 18. And I have a son who's 21, and the first time he got a medical examination done for his job, he was found to be hypertensive with ECG changes. So that was the first time he'd ever got investigated. And had he not been subjected to that investigation during his job initial physical examination, we would have never picked it up. So you recommend?
But I would still go back to the history taking and the clinical examination. We cannot afford to.
If that history taking and clinical examination is asymptomatic without any clear red flags, would you still advise an ECG in all patients?
No, then I wouldn't, at least not in that age group, because the risk factors are not there then. When we need to stratify the risk stratification, then it kind of becomes an all and run rule, you just keep doing. No, we need to have an outcome. So why are we doing ECG? Are we scaring the parents? 14 to 18 ideally does not warrant an ECG, but yes, clinical examination should. Is the child obese? Is he on is there a very strong family history? These are things which we can definitely ask.
Okay, so that means instead of just having a blind cutoff age value where you say this number do ECGs and this number don't do ECGs, take a detailed history and keep your eyes open for factors which can trigger a cardiovascular disease like smoking or obesity or a family history, maybe hyperlipidemia. And in these cases, irrespective of the age, you suggest that we do an ECG.
Absolutely. Absolutely.
What about a 2D echo? Should it be done for all patients? Should it be done for all those patients who have an abnormal ECG? Or is there any other indication?
No. So indication is abnormal ECG, high risk category, new onset hypertension, then dyslipidemia in elderly people, not in everybody. But these three places where you're looking at surgery, you should check. You should definitely do an echo.
Okay. Oh, thank you so much.
Ma'am, what is the cutoff level of TSH in a hypothyroid patient where you have to postpone the elective surgery? As
If
well,
if the TSH is above 10, because between the if you look at the lab values, it will say, some will say 4.5, some will say 5.1, depending upon their guideline, their lab parameters. So what we do is, if somebody comes into the subclinical hypothyroid range, unless they are pregnant or they are on the chemotherapy, we do not even think about starting them on any medication, but essentially the free T3, free T4 will be normal. If the TSH is above 10, you need to start the patient on thyroxine and wait for 3 weeks minimum for the thyroid, the TSH to go down, and only then we give surgical fitness
and
for
in a
surgery.
similar fashion, what about the antihypertensives? For how many days? So for example, it's a new diagnosis, antihypertensive, we have to do an elective case. For how many days the antihypertensive should be given, and then we should do an elective case?
Depends upon the control. If the blood pressure is under good control, if you're able to bring it down with a minimum medication, you can wait for 1 week. It depends upon the diastolic cutoff, actually. If the patient, so we look at it like this. If somebody is in high risk, 140 to like 85 to 90, we are okay with giving the surgical fitness. If the blood pressure, diastolic blood pressure is between 90 to 100, we start them on one antihypertensive, check after 48 hours, and then give fitness. But if the patient has a blood pressure, diastolic blood pressure of above 110, I would start the patient on 2 drugs, wait for at least 2 weeks, and then post the patient for surgery, because there is a very, very big chance that this patient will not take the medicine.
Thank you. Thank you so much. We'll give Dr. Vidya a break. She's been speaking non-stop for the past couple of minutes. We had so many questions for her. So, Dr. Raghu, other than echo, any other specialized investigations? Say, for example, you would want to do PFTs in which category of patients when they come for PSC? Is there any
PFT usually we would like to get it done for any patients who have earlier history of asthma, bronchial asthma, COPD patients, ma'am, and even patients in engaged group where we are seeing a lot of patients addicted to smoking. I would like to get a PFT done. In some cases where we have found to be PFT to be added up in our protocol, we have added up in cases where post-COVID conditions, patients who are being posted for elective surgeries, for them also in our institution, we have included PFT to be done now.
Okay.
This is
so
what
you do a baseline bedside pulmonary function test before you advise them to go to the lab and get more detailed analysis done?
We will get a
ask them to go to the lab and get the PFTs done.
No, ma'am, we will get a baseline PFT done with the spirometer, incentive spirometer at the clinic, PAC clinic in the institution. And if you find the patient to be having some abnormality, suspecting correlating with his chest X-rays, then we will advise them to go for a lab to get a proper pulmonology.
So a clinical indication, what you probably mean is that a clinical indication should trigger a baseline bedside evaluation. And once that bedside evaluation is done, only then for those indications, you should send the patients to the lab for a detailed PFTs.
Yeah, that is in institutional practice.
What about patients who are already on anticoagulants? Dr. Katikar has already brought this point out. So if you have your patients who are already on anticoagulants, Dr. Katikar, do you send them for any more investigations into detail out and bring out the dysfunction of the coagulation system? What is generally your practice? What do you do? Say you have a patient who is scheduled for a hip replacement or a knee replacement. Many of these patients are on anticoagulant therapy prior to surgery. Do you investigate them further before you send them for PACs?
The guidelines for orthopedic surgery and neurosurgery are totally different.
Right.
Orthopedic people, after operating the fracture neck hip, they are so worried about the deep vein thrombosis. We are also worried, but we are not daring enough to start it on second day, the anticoagulants.
Right.
So it is taught, it is given in the guidelines, it is given in the textbooks that as early as possible you start, but after operating a third ventricular colloid cyst or a huge meningioma, So none of us, whatever senior they are, they would try to start the anticoagulants immediately. So similar thing happens is that in an orthopedic surgery, you have operated a fracture, the patient is oozing. They just stop the drain. That the bleeding stops by tamponade. We can't afford that in brain. So smallest amount of bleed is catastrophic for us. So for us, the achieving hemostasis is, if not more, equally important than removing the lesion. So whenever these patients have these issues, we routinely do PT-INR and APTT. Once these two come, because one is the external pathway and one is the internal pathway, if they are in the normal limit, then only we go ahead with surgery. And in these patients, if they are on anticoagulants, these two investigations, they suffice for us.
Right. So, Dr. Jyoti, what about, what is your opinion if the patient is on antiplatelets, for example? What advice and what investigations would you do further before the patient is taken up for elective surgery?
Ma'am, nowadays it has become a practice to be on antiplatelets or antithrombotic agents or combination of antiplatelets and antithrombotic.
Right.
So the most common antiplatelets that is being used, cyclooxygenase inhibitors, is aspirin.
Right.
So, and the dose that we are using is 75 milligrams. So it is definitely less than 200 milligram. So for that, there is no absolute indication to stop the drug prior to the surgery. But if anybody wants it, they can do it for 3 to 5 days. But there will be, for that, they have to, the patient has to undergo platelet test or bleeding time, because we have to test the qualitative assessment of the platelet has to be done. So, but in as low dose aspirin, there is no requirement of any test prior to taking up for surgery. Rest, the low molecular weight heparins and other things, whatever the direct oral anticoagulants they have said.
Right.
So for that, they require PT tests, prothrombin time. Better if you do the INR, as the neurosurgeon has already said, the normal range is 0.9 to 1.2, maximum 1.2. In neurosurgery, a lower is taken for, before we take up for the patient, because like in surgery, even if it is 1.5 INR, we will take up for the elective surgery. But in neurosurgery, in ocular surgery, such patients are not taken. So, but the current scenario, most of the patients are on rivaroxaban, epoxyban, and other drugs. So for that, there is no investigation that is recommended. You just have to wait for 3 half-lives. So for if a small dose is given, then it is 1 day is sufficient. But in other, you have to wait for 2 to 3 days.
Right. So you are saying you will rely on the time, and at least for low dose aspirin, you do not investigate these patients any further.
All thing can be done, but you have to be, even epidural can be inserted, single shot can, but you have to be vigilant enough for the bleeding, but no further testing is required. Okay. If you want to do, bleeding time can be done. If it is prolonged, then you may avoid catheterization.
There is, see, bleeding time does tell you
qualitatively about the platelets.
All the evidence indicates that the bleeding on table is not linearly associated with abnormalities of bleeding time. It may so-called tell you that there is a qualitative effect, but no robust data to connect the amount of bleeding to linearly increase bleeding time. There are better tests available today. You may or may not have them at your center for evaluation of coagulation status, but that is not the current focus of discussion.
Yes, ma'am. It is PT.
Just trying to determine what tests would you like to do if your patient is, or say, on aspirin or low dose.
No, ma'am. No test is required.
No test. What about you, Dr. Gauri? Would you like to investigate these patients further? Say, if they are on aspirin, you have a patient on low dose aspirin continuously, vis-a-vis a low dose heparin, molecular weight heparin. Would you investigate them any further, or?
I will do a CBC first of all with the platelet count.
Right.
And the BTCT, although they are reflective of the results when the coagulation factors are down by almost, say, 40%, they are not of that much value, but then they are very handy. So they can be done at the bedside. And the prothrombin time, the APTT and INR, that is what is available in our city. So we do this, but then there can be other tests like platelet function assay 100 and for anti-XA assay, which is more specific for low molecular
Which is not
weight
specific,
heparin, but then
doesn't
it
really
is
give
not
you any valuable information. Right?
Yeah. So, but then we are not having it.
So that means, you know, when you read the guidelines, all the guidelines do come with a tagline saying that do not ignore clinical factors, do not ignore history and examination, do not ignore the type of surgery, do not ignore your own clinical sense. You know, when you are going to take up a patient for a surgery, the type of surgery, the loss also will be factored into whether you want to get more investigations done or not. So that, you know, clinical judgment always should be accompanying your guidelines as to whether you would like to do further investigations in a patient or not. So when you do these investigations, let's now come to the point as to when and how you will accept them. Would you like to have investigations which are a month old, 2 months old, done day before yesterday, morning of surgery? What is the limit for accepting patients with a set of investigations? Today only in the PAC clinic, we had this patient who was for recanalization. She had come to us a year before, then absconded. Now she came back with the desire of now bearing a child again and was scheduled for a recanalization, but all her investigations were a year old. She was otherwise absolutely normal, no history, no significant examination findings. She was ASA grade 1 with no other comorbidity. So should we accept these investigations or should we get them done all over again before we give her fitness for anesthesia? Dr. Chauba, would you like to give us your opinion on this?
By the guideline of the ISA, if you see the guideline of the ISA, what is they said is that if the investigations are less than 2 months, if the investigations are less than 2 months, it is well and good. If there is only one clause, if there is no changes in the clinical condition, if there is no change in the clinical condition, the last 2 months, and then investigation done within that 2 months, then we can take it. For ECG and X-ray, they said up to 1 year. After 1 year, ECG and X-ray, if there is no changes in the clinical condition. So 2 months is good enough.
Okay. Okay. So Dr. Chauba is referring to the ISA guidelines saying that if there is no change in the baseline clinical status of the patient, if there's no fresh complaints, if the physical status is the same, then probably investigations which are 2 months old can be readily accepted. And probably, as he said, for ECG and X-ray, the cutoff value is almost a year that you can accept those findings. Probably if there is no change, suppose in between patient has developed hypertension, or today you find that the patient is hypertensive and in the previous visit he was not. So probably then, you know, the course of investigations may be changed. Is that the same practice which you follow, Dr. Raghu?
Sorry to interrupt, ma'am, but we are just running out of time, so we need to expedite our discussion.
We will just wrap up. We will wrap up in 5 minutes, Rashi.
Ma'am, in our rural setup, usually if the patient is asymptomatic and the investigations previously done were within the normal limits, according to the age group, I will take up the case. If at all I feel anything amiss in the investigations, reports to the clinical picture, what is present on the present day of surgery, I would like to get the investigations done according to the need, ma'am. Right. Otherwise, 2 months is good enough for the blood investigations. Regarding the ECG and the other investigations, chest X-ray, I will accept it if it is found normal within 1 year period.
Okay. Okay. So what about emergency cases? We've been talking about elective cases all throughout, but emergency cases are a staple of our practice. So suppose you have an emergency LSCS. What investigations would you do for that patient, Dr. Jyoti?
Emergency LSCS. She will be ASA 1 patient, most
ASA 2.
ASA2
pregnant
patient.
patient is, if nothing else.
Yes,
then
yes, ASA2. Sorry. ASA2 patient. So a complete CBSE will be done in such scenario. And as you've said, blood sugar, I wouldn't have otherwise gone in for that, but blood sugar and no more investigation is required.
That is for an emergency section also, or would you like to just suppose the patient has fetal distress, she has meconium staining, she's for a fetal distress, would you accept her or would you insist कि एक bedside hemoglobin कर लो, एक bedside blood sugar कर लो?
CBC I've said CBC तो करना पड़े, hemoglobin तो करवा लिया उसका, CBC तो
करवाना है। ओके डॉक्टर गौरी आप बताइए, इमरजेंसी LSCS अगर आपके पास आता है तो आप क्या इन्वेस्टिगेशंस करवाते हो?
Madam, they will come under, as you said, this
ASA2.
ASA2, yes.
Right.
So I will get a CBC done. I'll get a serum creatinine done, and yes, blood sugars are always done for the this patients to see gestational diabetes. So that is one thing I'm going to do. And
लेकिन emergency section में ये सब कराने का अगर time ना हो तो would you still insist कि
I will.
एक bedside कर लो, एक blood sugar कर लो, एक hemogram कर लो, अगर patient actually fetal distress के साथ आया है तो क्या हम उसको ऐसे ही नहीं accept करेंगे बिना किसी investigation?
Yes, I will examine the patient. Yes, I will examine the patient. I will see the previous papers or her ANC reports. And then, yes, we will definitely proceed for, if it is an emergency surgery, we'll definitely proceed for it.
Okay, what about an emergency neurosurgery case, Dr. Katikar?
Madam, the emergency neurosurgery is not done like on the spur of the moment. Except an anecdotal case of extradural hematoma, which is very massive and which is touch and go, we take him to the OT and do burholes without doing anything. Otherwise, even all the emergencies, we take time at least 20 minutes to prepare the OT trolley and the table. That much is enough for us for doing all the investigations. And as I said, any bleeding there or any other issue, any slightest infection in neurosurgery is not acceptable because there are catastrophic outcomes.
Right.
So I am sure none of the neurosurgeons are taking any chances of doing less investigation. Maybe they may not be doing the 2D because it is not available at that spur of moment. But otherwise, all investigations will do.
Right. So the gist of these two cases at the end being that, as Dr. Katikar or probably Dr. Gauri has said, your clinical condition and the urgency of the situation demands what investigation you do. Where a baby and mother both are at risk, you'll just take the patient for emergency surgery without really going into the dynamics of more investigation. Whereas Dr. Katikar has said his patients, the potential for harm is so large that probably he'd like to do a little bit of investigative analysis before he takes up the patient for surgery. So what about erroneous investigations? Dr. Srividya, do you actually ever come across these erroneous investigations where the patient
Sorry to intervene, ma'am. There is a question in the chat box regarding the fetal distress with eclampsia for an emergency surgery.
Okay, fetal distress with eclampsia. Can I answer that on the behalf of somebody who's been doing eclampsia for 20 years now? So if there is fetal distress with eclampsia, your outcome is dependent on your investigations. Your course of anesthesia, your decision on what anesthesia to give itself depends upon your investigation. So you need to look for raised ICP. You need to do a basic coagulation study. That is mandatory. Otherwise, you cannot give regional anesthesia. And if, God forbid, it is such a case where you do not have time at all, then we go ahead and give general anesthesia because that would be safe in the absence of any investigation for the coagulation status. So I think this itself, by itself, is a complete case discussion. So it will impinge on our time. We can take more questions on the chat box regarding eclampsia and PIH and investigations, where we'll just close this discussion by asking Dr. Srividya as to, does she really come across this category of patients where the patients appear absolutely normal and the investigations are abnormal? Then what
plenty.
happens?
Plenty.
Then what happens?
So we have to take it on the case-to-case basis. Say, for example, a patient is coming in for a acute, like a fracture, and we realize that the LFT is abnormal. So do we have to look at the outcome. It depends if the fracture, the surgical impact is more, or the thing, we can wait. But if it's an emergency, like I said, I come from, I know Dr. Gauri knows, we are from a place where we have minimum resource at that point of time. We were told if a patient is having an MI and a ruptured cataract, we go for the cataract because we can't afford to lose a grievous injury. You know, I mean, these are the things which we come from. So we manage the reason for the abnormal LFT. If, say, for example, it is a fatty liver or a non-alcoholic steatohepatitis, there is no emergency. The results can be abnormal. We don't treat reports. We treat patients. So we look at the risk odds ratio. What is this going to cost my patient if I say yes to this going ahead with the surgery, vis-a-vis if I don't allow the surgery to happen, what is going to happen? So we don't treat reports. Abnormal reports are going to be there because most of these labs may not be accredited. But do we really know? Is it worthwhile wasting time in repeating? Go ahead with the surgery. We are here as a backup. We will handle it. This is how it works.
So there is nothing to supersede common sense and clinical evaluation. And erroneous reports by themselves should not raise a red flag. They also must be evaluated in conjunction with the type of surgery, your patient, the risk factors, the adverse outcomes expected. Everything together should be complete, wholesome evaluation rather than just evaluating the reports. And one final question, I think we will start here with Dr. Bajwa. I want to include him in this discussion by asking him what are the medico-legal implications of not ordering investigations when they were supposed to be done. So is there a medico-legal implication on all of us if we don't order a certain preoperative investigations, which we at that time probably would have felt is not required?
The most difficult question you have kept for me, I think.
Absolutely, Dr. Bajwa.
Rather, I was thinking of summarizing and ending up the discussion, and you suddenly threw a time bomb on me, rather. So coming up to the medico-legal aspect, we will start from this thing regarding the unbooked case, coming for the emergency, the decompensated patient. Now, there are two aspects to that. First of all is whether the patient safety first. As the patient will be safe if we take up for the surgery. I think there are two lives involved. One is the fetus and one is the mother. Second part is the safety of anesthesia and surgery in these type of patients. Then come the third is the medico-legal aspect in this type of case. So here, with the clinical acumen, with the wisdom of with the experience of your life, with the learning, you have to deal with these cases at that particular point only. It is called point of care. It's the point of, point of treatment. Now, I think without wasting time, you should take a video consent or written consent, especially mentioning the condition at that particular time in the language which the patient's relatives understand the best.
Right.
Once you take up the consent, you have almost covered 80 to 90% of the medico-legal provision.
Okay.
Now, coming to the clinical part, see, the surgeon knows, the obstetrician knows best how to handle such patient, and you know how to handle these things. So there goes the teamwork. And if anything happens, we can always call the cardiologist or the physician, which you rarely find on the peripheries. So you are the perioperative physician, you have to take up the case, but the medico-legal part, you have to cover yourself by taking a valid consent, enumerating all the comorbidities, enumerating all the risk factors, so that you go ahead with the surgery to save the life of patient. That is our first motto. Then coming about the investigation for the elective surgeries. What investigation? Now, there was a comment there by Dr. Naveen also. Definitely the Western countries and the corporate sector in our country, in the rural sector, and in the medical colleges, we order a different set of investigation. The level of investigation varies. Coming basically to that, I don't find anything hurt if a surgeon orders the investigation, obstetrician orders the investigation, because they are also clinicians. They have also through their life, they know what are the values of this investigation and how the patient will behave during the surgery if any particular investigation is wrong, and which are the minimum set of routine investigation. Here comes the role of modern anesthesiologist, who should be knowing that apart from these basic investigation, what else he is required to make the surgery in anesthesia safe in that particular scenario. Again, if the anesthetist make a decision here, that means which investigation is important for that particular surgery. He is covering up the medico-legal part.
Right.
So medico-legal part is not that difficult to cover if you learn with your years of experience, with the theoretical, with the practical knowledge and the clinical knowledge. Medico-legal part is mostly covered except for the negligence or the lack of skills or a lack of, something. And there is a very thin line between a therapeutic misadventure and a negligence. So you have to define, you have to document. The documentation comes the next. Once you take up this case, the documentation has to be in proper format from the beginning of the case till the end of the case. You have to write everything along with surgeon's perspective. Don't change the documents. Don't change the, whatever the timings as well as the clinical notes. The surgeon and your notes should be similar. In case of any uneventful or eventful things happen, the note should be similar. I think we should not be worried about the medico-legal aspect, because our branches, all these clinical branches, are always going to be challenged by the medico-legal aspects. But we should be well prepared in the documentation, in the clinical decision making, and in the evaluating of the patient.
Very, very well said. So communication is imperative and documentation is very vital. And documentation of this communication and communication of the documentation are all vital to protect you in these kind of scenarios where you have probably not adhered to the so-called laid down guidelines for investigations. So we've covered a vast spectrum of elective and emergency surgeries. So if time permits, we can show the 2 slides for the national ISA guidelines. But they have been put forward in the groups. They are available online. These recommendations are very, very lucid. They've been beautifully put forward. So if it's the opinion of the House that we should put forward, we have 2 slides. Should we just briefly show them? Dr. Nishant?
Sure.
Will
Yeah,
you
just a brief outline.
Yeah, it just takes probably 30 seconds to outline that. So this is essentially an amalgamation of what we've discussed for 2 hours. And the recommendations are very clear, they're very lucid, and they are for all the tests that we've discussed. Preoperative blood count testing is suggested for all patients undergoing minor, intermediate, or major surgery. Preoperative creatinine estimation is not recommended for minor surgery, but recommended for intermediate and major surgery. Similarly, electrolytes are not recommended for patients undergoing minor, intermediate, and major surgery if the patient does not have any other problem like drug intake. Preoperative liver functioning assessment is not indicated in minor and intermediate surgery, but should be done for patients undergoing major surgery. Preoperative coagulation profile is not suggested for elective surgery, minor, intermediate, or major in ASA grade 1 and 2 patients. Non-diabetic patients, preoperative blood glucose is not suggested. We've already had a detailed discussion on this. The next slide, Dr. Nishant. In non-cardiac patients, preoperative 12-lead ECG is suggested at an age of 45 years and above. We've also had a discussion on this. Preoperative 12-lead ECG should be done for all major surgeries, but as for minor and intermediate surgery, there is a cutoff of 45 years. Preoperative X-ray is not recommended for minor surgery, and above 50 years may be done for patients undergoing intermediate and major surgery. Preoperative ultrasonographic airway assessment is not suggested as per the current literature and available evidence for predicting difficult laryngoscopy. You can do that by other clinical tests. The validity time, as we've discussed for investigations, is approximately a period of 2 months, provided there is no clinical change that the patient has undergone in the intervening period. The accepted validity time for an ECG is approximately 12 months, provided the patient has undergone no further change in his clinical condition. Thank you so much for those slides, Dr. Nishant. And I think we've had an extremely fruitful discussion. I would give the stage back to the academic coordinators and place on record my extremely heartfelt thanks to Dr. Raghu, Dr. Gatikar, Dr. Choba, Dr. Srividya, Dr. Gauri, and Dr. Jyoti for this extremely interactive and enlightening discussion. The person who's benefited the most is myself. In the past few days, I have really learned a lot of new stuff regarding preoperative investigations. Thank you for all the support, Dr. Madhuri and Dr. Nishant. And of course, warm thanks to Dr. Bajwa for taking this forward and ensuring that this vital discussion took place this evening. I'm sure all of us have benefited. Thank you so much.
Thank you so much, ma'am. It was lovely, really a great pleasure to have you as the moderator and the eminent panelists to conclude this particular CLIP webinar. And now I hand over the stage again back to our Honorary Secretary ISA National, Bajwa sir, to summarize a little bit of what the exact CLIP webinar carried forward with this.
I think we had many summaries during the entire discussion. I don't have to summarize entirely. It's difficult for a human being to remember all the things, whatever has been discussed.
Right, sir.
Actually, this panel discussion required in 2 or 3 parts. Part 1, part 2, part 3, so that we could have a very comprehensive and complete discussion on these preoperative investigations. Anyway, but the involvement of the surgeon and the physician in this discussion, it adds flavor, it adds, a vitality to the discussion. Many things I think we miss, which are, suppose one thing I will like to highlight here, accidental detection of diabetes or hypertension or something when the patient comes to you for a PSC, first time in his life, he or she comes to the hospital and you detect it. I think there comes a role of physician first, because internal medicine is a subject which anesthesiologists are not taught during their MD. That is a part of the physician, how to go about even prescribing an antihypertensive. You have to ask a very detailed history, which I also don't remember how to take. Patient having a thyroid disease, patient having comorbidities, which antihypertensive say, which is not. I think that's the area of a physician. Otherwise, if the patient is already on medications and coming to you with something with a controlled or uncontrolled values, you can always take your clinical acumen into practice. But if it's for first time, I think it is always advisable to go to the particular specialty for evaluating that patient to ensure a better safety in elective surgeries. I'm talking. The second good point came from discussion today. It's a very vital. Dr. Ranju discussed in the beginning. A patient, and many colleges also, medical colleges also, the PSC is given the least importance. Either a PG student is sitting there or a SR is sitting there. I think there comes a role of a consultant there. The consultant, what he picks up, the comorbidities or he can plan the anesthesia for that particular patient is very important. And to add to it, suppose now with the new rules by the NMCs, we have been divided into units. The anesthesia units are also coming up. So it's better. Tomorrow, which anesthesia person will be on duty, suppose a senior resident or whatever, that person should be sitting in the PSC prior to that, so that he or she can manage that case well when that case present to the operation table, if we are going to make that case fit for that particular surgery. Rest, I think this discussion has stimulated the formation of more comprehensive guidelines, which I think we will be starting soon on this aspect, where the involvement of the different specialties and super specialties is important. I cannot say that anesthesiologists are perfect in making anesthesia guidelines. Similarly, for other specialties also, if a surgical specialties, if they want to make a surgical guideline for a particular subset of patient, involving anesthesiologists is always good, because it makes a complete set of clinical discussion, clinical grinding, and evidence-based and resource-based, whatever things are there. All the shortcomings are covered up if you involve the other subspecialty and specialty. And I think in Indian society, ISA will be striving hard in the coming days to involve all the specialties and super specialties of different fraternities, whether medical or a surgical, to make the comprehensive guidelines for our better safety of patient. This is on the cards. I'm telling you, we will be releasing very soon. Those things will definitely come up. First time, so many specialties will be involved in forming a guideline. I think rather than ICMR giving us away, projecting us away, we are the physicians, best brains behind a continuation of the medicine in our country. So why can't all we unite to form a guideline rather than just a few people sitting on administrative blocks forming a guideline for you? You people having a clinical expertise, clinical experience, you making a guidelines. So that is the way to go forward. I think few of the specialties have already started doing that, and we at ISA, we are definitely going to do that in a very near future. Only thing is there's a shortage of time at the moment. Even our guidelines are also, there are few guidelines which we have already started, but they are just have to show on the day of light, but that will also come soon. But I am really thankful to Dr. Ranju and all our panelists, academic facilitators today, without naming anybody, because this discussion was required and it was done in a very good manner. And our academic moderator, Dr. Madhuri and Dr. Nishant Sai, and our program head, Dr. Manoj, they have always been there with me, helping me in each and every aspect of these type of discussions. So this is my summary from my side, but I still require, I think, few comments and suggestions from the audience to be taken in the next 10 minutes before we finally wind it up.
Any particular questions we've missed in the chat box, Mayank and Rashi, which really need to be addressed? I think majority of them have already been answered in the course of the discussions.
I think most of them were answered during the discussion.
Most of them were answered, but there is one important thing that Dr. Venkatgiri sir took up. That is, HbA1c found suddenly to be abnormal and an emergency laparotomy to be done.
That is Dr. Sri Vidya, I think, can highlight on that.
Right.
Got left in between.
So, see, when we look at HbA1c, we are looking at tracking the history of whether a good controlled sugar or a poorly controlled sugar for the last 3 months, 90 to 120 days is what. But when we break up these, suppose somebody is coming to you with a blood sugar HbA1c of say 10, it is probable that his sugar has gone up in the last 2 weeks, also attributing to at least 2% of the hike in HbA1c. From 9 to 10 or 8 to 10, it could have gone. But that should not stop us from taking the patient for surgery. I have been part of a team wherein, suppose a patient is coming to me with 450 or 500 sugars, and this surgery needs to be done. Patient is under a very time period. They have to go back to, I would put the patient on infusion, start the patient on long acting, let the patient go in for the surgery and tackle the sugars at the next 3 months level. That should not, because the patient has already learned a lesson that I need to get my sugars under control. So HbA1c is one criteria which will tell us how long the sugar has been bad, how much control I need to do for the surgical requirement, and how should the patient be handled in the next 24 to 48 hours post-surgery. I hope this is clear.
Yeah, if I can just add to this little bit, the HbA1c or blood sugar levels control depend entirely on the urgency of the surgery. If it's a laparotomy that the patient has been brought for, till you take care of that laparotomy, take care of probably the perforation or whatever has happened inside, blood sugars cannot be controlled in the absence of that definitive surgery. One. Secondly, you must understand as to what the problems are being caused by the raised blood sugar. It's not the blood sugar per se, but it's the effect on the other systems which are going to cause an adverse outcome. Majority of them are related to loss of electrolytes and dehydration. So if you take care of the dehydration, if you correct the potassium, that will take care of 80% of the adverse effects. You needn't really bring the blood sugar to a so-called level before you take the patient up for surgery. But yes, if it was for elective surgery, I would have a more conservative view and try to control the blood sugars, because hypoglycemia is a toxin by itself. So the adverse outcomes in those conditions are different. So the timing of surgery and the urgency of surgery actually decides what further course of action to be taken.
And
So
the next
in-
question
I
is
would add one last thing in this is that, say, for example, a patient who is under fairly good control with a HbA1c of 7, but just prior to the surgery, the sugar is high, I would err on the cautious side with what insulin I'm using, because these are the patients who will actually end up with hypoglycemia. So the stress of the surgery or the stress of the primary problem is what is hiking the sugars. We need to go a little easy on these patients. They will not have a bad outcome. This is a very documented finding. This is where the HbA1c plays a role, not in the surgical decision making.
Right, well said.
respected Dr. Malhotra, sir, any comments?
Yes. Good evening, Dr. Naveen.
Good evening, sir.
Excellent discussion, madam. I think you need a voice rest. You have been on the mic for almost 2 hours continuously, and very nicely summed up and covered almost all the aspects of the topic, and really hats off to you for your energy. See, at the end of the day, I can say we are having the investigations. Gone are the days when we were short of investigations. India has progressed that far. You name any investigation and you have it. But more than getting an investigation done, it is more important is interpreting it and correlating with the patient's clinical scenario. And we all know each individual is a different patient, and we have to tailor-made adjust the investigations, get the investigations done according to the type of the surgery, type of the patient, and type of the setup in which we are. At the end of the day, if we want that, we need that investigations, any particular investigation, we should get it.
Right. Thank you so much.
At least give me some time for felicitation of our chairperson, moderator, and panelist. Dr. Giri sir is there or not?
I am there.
Oh, Dr. Giri,
Today I am there. You think that?
with your permission, we are going to felicitate them. Shall I go ahead?
Please. You
Okay.
continue. Naveen is there. You are there and all. Please
No,
continue.
certificates. We have to give certificates.
Okay. Yes.
Able to see the screen?
Yes,
Yeah.
we can see that.
So this is Dr. Ranju's certificate. Okay.
Right, sir.
No.
Not able to see, sir.
नहीं दिख रहा रंजू का certificate.
नहीं दिख रहा.
It is there in the side, the small one. It has not come to the main screen. Yeah.
Anyway, it will be seen now, na?
Yeah.
Now visible.
Yes,
Okay.
Make it big, so wide.
I think
Screens.
let it
You have
finish.
to make it.
My name is also there. Good.
Good.
Make
Sir,
it
your name
wide.
will always be there. Then Dr. Jyoti Pathania,
Thank you. Thank you so much, Dr. Bajwa.
Dr. Datta Prasanna Katikar, sir. Yeah. Dr. Shri Vidya, madam.
Thank you very much. It's an honor.
Dr. N. Raghunandan.
Thank you, sir.
And Dr. Chauba Singh. Dr. Gauri Arora, madam.
Thank you,
Dr.
sir.
Rashi
Thank you for the
Sarna.
opportunity.
Dr. Mayank Masan. So
It's an honor.
it was a felicitation and special certificates to Dr. Madhuri and Dr. Nishan, because they are our coordinators, and best certificate to Dr. Manoj is a program head. So Dr. Manoj and Dr. Giri, you please both curtail the program. I think the first Dr.
For
Manoj,
participant also certificate. Bajwa.
you also require, sir.
No, participant, delegate certificate.
So I have to get a GC approval for that, the finance part.
No. You give e-certificate for that for people who that ask the question.
For next time, we'll give the e-certificate also.
Yeah.
Dr. Manoj, you want to say something last?
No, I will give vote of thanks. If
Yeah, please.
you
Yeah,
permit.
please.
Good evening, everyone, to the one and all present here. It is such an honor for me to get the opportunity to give vote of thanks. I express my gratitude to our visionary ISA National President, Dr. M.B. Bhimeshwar sir, for his guidance, support, and blessings. I would like to thanks to our dynamic ISA National Secretary, Dr. Sukhvinder Jeet Singh Bajwa, for his day-night hard work for the society and which lead to our ISA flag is flying high. I thanks to ISA National Chairman Academic Committee, Dr. Venkatgiri KM sir, for his help and guidance. My sincere thanks to ISA National Immediate Past Secretary, Dr. Naveen Malhotra sir, for doing excellent work for our ISA society. I would like to thanks to our esteemed governing council member for his support and guidance. I would like to express my sincere gratitude to the today's webinar moderator, Dr. Ranju Singh Madam, and enlightened all of us with innovative ideas on essential preoperative investigation. Thank you and hats to you, Madam. Hats off to you, Dr. Ranju Singh Madam. I would like to thanks to all the panelists of the today webinar on essential preoperative investigation, Dr. Gauri Arora Madam, Dr. Datta Prasanna Katikar sir, Dr. Jyoti Pathania Madam, Dr. Chauva Singh sir, Dr. Raghunandan sir, Dr. Sri Vidya Madam. You gave the answered all the question in excellent way, from which all the member of our ISA got benefited. Thank you so much to all panelists of today's webinar. My sincere thanks to Professor Dr. Madhuri Kurdi Madam and Dr. Nishan Sahai for their help in the conduct of this webinar. My sincere thanks to academic facilitator Dr. Rasi Sarna Madam and Dr. Mayank Masan for their excellent work and hard work for arranging organizing this webinar. I thanks to all the faculty who gave their valuable feedback and participated in the discussion. Thank you once again to all of you. Long live ISA, long live ISA. Jai ISIAN.
Thank you, Dr. Manoj, that this is you always make my work very simple. I forget names, you always remember. That's how the team works, and this is the best, very simple vote of thanks. I love it. I will always love it, and you will keep helping me like that always.
Thank you.
And with such a good show coming to an end, I will say good night to everyone with one word, one line, one sentence. Long live ISA.
Long live ISA.